Hello, everyone. So far, we've been building upon the RAVR experience, stepping up from setup, tableside choreography, and the performance of straightforward RAVR, both tissue valves and mechanical valves. What happens now when we start to approach more complex patients, such as those with bicuspid disease, where that calcium can not only encroach the sinuses, but also deeper down into the left ventricular outflow tract? Those patients may not actually be a good candidate for transcatheter therapy. Sternotomy aortic valve replacement may also not be ideal. So join us in this episode where we're going to start to approach much more complex calcific pathology and how, with precision, we can mitigate the chance of stroke by very detailed and precise visualization and aspiration at the time of performing a seamless RAVR. So, what happens now when the anatomy is not so straightforward? As you've seen, as we've gone through these different videos sets, we've been increasing complexity. And here we have a patient who presents with severe bicuspid disease with heavy burden of calcium. And we'll show some cases here now of how we manage severe calcium. So exposure and how we're starting to get into the situation where the patient's calcium is fairly extensive and entering into the left ventricular outflow tract. We have tandem partnership with the suction aspiration to really stay very flush with the annulus, as it is so very important for the to avoid paravalvular leaks and have a good, durable, long-term result, to really remove as much, if not all, calcium as possible. So many of my surgical colleagues around the world will recognize these types of valves that are that we'll see in this episode that are difficult, but actually a nice challenge as we sort of focus on precision. Here we see we're getting under the calcium. While it looks quite unruly now with all of this calcium, this is the same situation in open cases. We just have to be very precise. And we get a nice flush debridement. And now we go after every morsel of calcium with suction and aspiration and irrigation, working together as a team. We would posit that this is one of the reasons why we feel that through robotic, our stroke rate is exceedingly low, if not near zero, compared to open surgical cases in calcific disease, because we're able to visualize every aspect of any type of particulate matter. And so here's our result. This is a younger patient also requiring a mechanical valve. As I'm sure our audience knows, that the bicuspid pathology is often found in younger patients, but not exclusively younger patients at presentation. So after complete debridement and meticulous decalcification, aortotomy is closed. Pacer wires are placed, and the patient is reanimated with a good result, no paravalvular leak, a mean gradient of 8. Now for a case that's even more calcific, and this heavy burden of calcium, the patient has aortic stenosis plus eccentric regurgitation. The calcium score was exceedingly high on CT scan, and we were not able to arrest antegrade only, so we had open and now arrest through the coronary ostia. And here we have another heavy burden of calcium. So we're working on resection. And we've got the one leaflet out, and now we're getting into the non. And finalizing here into the left ventricular outflow tract. And I think if you can get this flush, it really helps with the overall performance and avoiding left ventricular outflow tract challenges post-replacement. So in this case, we were able to peel the calcium off of the left ventricular outflow tract and perform a bioprosthetic RAVR with good result. And good hemodynamic result, no paravalvular leak, and excellent flow in the outflow tract without obstruction. Now here's a case that's even more extensive, and this is a patient who likely had some radiation in the past, who was in his 70s, who had severely calcified trileaflet aortic stenosis. And this is where we have to be very precise because there is multi-level stenosis, as you can see, in encroachment not only LVOT, but also on the anterior leaflet of the mitral valve. So we have to be very focused and remove any and all particulate matter, but also, more importantly, attempt to navigate this more penetrating calcific disease. As many of my surgical colleagues have been in this situation, these can be challenging cases, but at the same time quite enjoyable and satisfying when we can get an excellent debridement. The important thing is to never leave calcium behind in a major way, but also be safe within your ability, your institution, so that we are not doing a full root replacement. You can see the penetrating calcium in the left ventricular outflow tract here. In this case, we're having to go slightly beyond the annular domain. We're starting to see a little bit of adipose of the root peeking through because we're gonna have to do that only because the calcium is so aggressive. And this just showcases that this is possible, much like you would do in an open case. You would do the same thing here in a robotic case. The robot is merely an instrument. The surgery is the same approach we would do in an open case. This is albeit somewhat complicated in that the calcium is so aggressive, but it can be debrided. And as you can see, we're getting that hooked underneath that big stalactite of calcium, and continuing the debridement. You can start to see a little bit of loss of domain there, which we will address. But the important thing is to get this calcium out. For our cardiology colleagues, this is exactly why we respect the calcium scores and heart team assessments, so we can determine the safest approach. So once the calcium of one leaflet is excised, we still have a lot of work to do. We still have some more to go. So now we go back to the left. You can see it's encroaching on the aortic wall here. So now it's time for some choices, because as we get close to the coronary ostia, it can become somewhat precarious in that the coronaries can get involved. So got to make some choices here. There is the pursuit of total calcium debridement, but then there's also safety and judgment. And in this case, I'm going to debulk as it pertains to the left ostia. I've been fairly aggressive over there, but this at the level of the right is relatively safe away from the right coronary ostia. So now we're going to focus on the mitral valve, this big sort of another stalactite sort of descending down onto the posterior surface of the anterior leaflet of the mitral valve can cause some not only obstruction in the outflow tract of the aortic valve, but also restriction of movement of the anterior leaflet. And oftentimes, transaortic debulking of this large chunk of calcium, particularly if it comes off in a seamless way, can actually have other advantages to the hemodynamic performance of the mitral valve in terms of its motion with minimal or reduced restriction. Sometimes this can be done, as you just saw, by squeezing the calcium, and then it somewhat peels off, sort of akin to what a rongeur movement would do, but without the need of a rongeur. So once we've debulked all of this, we then spend a lot of time with very aggressive irrigation. So we intubate the left main ostia and irrigate both in the ventricle and the aorta because of any calcium that may have flung off during the debridement. So now we have a fairly decent, not total because of the penetration aspect of debridement of all that calcium. And this is going to be smooth and this will be fine. But you can see that we did have a loss of domain here, and I'm a little concerned that we've had some minor annular disruption. So just as a safety precaution, I'm going to reconstruct the annulus here with a running 4-0 monofilament suture going up to the just before the commissure, and then back along. This is about 50% of the right corner where we really had to be aggressive, as you may recall. So now we've kind of rebuilt the annulus to my satisfaction, and then placing the sutures. As you notice, we really don't have to use pledgets. We tend not to use pledgets, but in this case, at this location, which is where we really had to get deep in the debridement, I'm going to support the annulus with a single pledgeted stitch, really just for added sense of security. This is a rare situation in our program because we don't routinely use pledgets, but it illustrates that you can't be dogmatic about everything and adapt to the tissue as needed. If pledgets are used in your institution, that is totally fine. Whatever is safe and whatever is routine, this technique is very adaptable to whatever situation you so choose. So this RAVR is now complete, despite its complexity, with an excellent overall result.
So now we've seen how to perform even more complex RAVR in the setting of heavy calcification. What about the patient now who has a small annulus or has the risk of patient prosthesis mismatch? These are situations where we need to put the largest prosthesis possible. So join us in our next episode where we're going to show how to perform root enlargement at the time of RAVR.